Good afternoon, ladies and gentlemen. We are moving to the next symposium now. The next symposium is on, quite appropriately, on COVID-19. Today, the first speaker is Colonel Dr. Savin Semage. He's the Deputy Director of Army Preventive Medicine. And as probably many of you know, he had been in the thick of this from last March. So he's going to talk to us how this quarantine process and how the military helped us in containing this illness and the present and future challenges. Over to you, sir.
Good evening, ladies and gentlemen. Thank you, Chair, for the kind introduction, and also I would like to express my gratitude for giving me the this opportunity to present in the prestigious College of Physicians annual sessions. Thank you very much, Dr. Ananda Vijayakram, sir. So my presentation is on the role of armed forces in the Sri Lankan pandemic response. So I would like to start my presentation with a brief introduction to the current situation in Sri Lanka. So as we all know that we are going through a bit of a increase in cases with two active clusters, Minuwangoda and Pratiyakota clusters. Of course, the Minuwangoda cluster is dying out right now with 36 more active cases to be discharged from the hospitals. And you can see that the Sri Lanka had been doing really well up until the early October. So we had a very good control, but now we have a bit of a hiccup right now. The other important thing is that with the treatment sector, we are still doing well. If you take the treatment sector, we are still 139th in the rank in the world compared to other indicators with total cases and active cases. So if we look at the epigraph, as we can see that we have a huge thrust in the from the early October, and we had some smaller clusters early on with Navy, Kuwait Flight and Kandekadu. We will come into that later. As we know that the Minuwangoda cluster started on 4th October, and it went on till about the third week of the October. Then it was dying out actually, but unfortunately on 21st, the next cluster from the fish market, Paliagoda, started, and we had the highest number of cases on the 23rd with 866 cases. And by now, during last few days, it is more or less constant with 300 to 400 cases coming up, reporting during last week. So we expect that this cluster would be there for some more time to come. So with this slide, I want to make the point that when we there is a debate about community transmission. So when we look at the community transmission, that the WHO newest position is that we can't take a country as a whole. It's all geographical, and we can say a lot of yellow spaces in Sri Lankan map. So it's more or less confined to the denser districts in Sri Lanka. So this fact has to be considered when we decide on our future strategies. So if we get down to the story so far in Sri Lanka in last 9 or so months, that we started with the first case reporting on late January. Actually, we were ready with our testing capacity when we had the first case in Sri Lanka. And it was the very first day that we had the task force formed in Sri Lanka. On the same day, we got the first case reported. And then the next highlight is the Wuhan rescue mission. It was exclusively done by the military. And it was to rescue or bring back the trapped Sri Lankan citizens from epicenter at that time, Wuhan. And we were, I think, third or the fourth country in the world to do so, after UK, USA, and Australia. And then actually it was a new experience for us in the military. We had never done this, and it was out of textbook we learned, and it was on the job training. And we had very limited time, but with a very small number, 33 people, and with almost ideal condition, we actually learned about how to do the quarantine, and we brought forward that experience to mass quarantining, which we started on 10th March. Again, we had very little time in Kandakadu and Punani. So that was a very good test rehearsal, the Wuhan rescue mission. And in between, we had this handler protest. That was again highlight in this journey, because the government decision was to institutional quarantine the overseas returnees from March 1st. But because of this handler protest, the health ministry couldn't materialize that decision. So we had a bit of a hiccup for about 1 week. And if we didn't have this handler protest, and if we started the institutional quarantine by March 1st, we would have probably avoided the lockdown that we had for about 52 days from March. So then the first death was reported from one of our quarantine centers at Galkanda, just 2 days after we started mass quarantine. And we had this Kandegadu Italian cluster. That was the first flight that we had from Italy. And there was a cluster, and this was the first time that we reported asymptomatic cases in Sri Lanka. And we had some local clusters from Putlam, Berwal, and so on and so forth. And we started mass testing in Punani. Nowadays, everybody at every MOH division, they do it. But it was the first time we started the Punani, as you can see in the photograph. And then we had the Navy cluster, the Kuwait flight. That was again highlight, because this is the time our treatment capacity was tested for the first time. Because we had there were about 475 passengers from 2 flights to Sri Lanka in 1 day, and 400 of them got positive. So we had about 875 active cases at that time in Sri Lanka, but that was too much for our treatment capacity at that time. So that was an eye-opener for the treatment sector. And then the Kandekadu cluster, it was a spillover from the Suduella cluster. Then it came to the Navy and to the Kandekadu Treatment and Rehabilitation Center. And then the Kandekadu Treatment Center, again a highlight in this journey. That was the first time that we introduced this intermediate care center concept that we are practicing now. So we had to convert the quarantine center at Kandekadu to accommodate all the positives from the Kandekadu Rehabilitation Center for security reasons. And we did it in 6 hours, even before the epidemiology unit declared the first 50 cases. And we all know about the Minuwangoda and Paliagoda cluster. So if we put it in another way, that you can see that there are a few bulging orange bulges that are the active cases in the 3 corresponding clusters. And then we have this Minuwangoda and Paliagoda cluster. So we had a fairly long containment phase in Sri Lanka till early October. And now we have moved into the mitigation phase, I would say. So what is the difference between the containment phase and the mitigation phase? Actually, the objective of the containment phase in any country to give a breathing space to prepare for the mitigation phase, with no cases or fewer cases in the community. And in this time, it's a health priority over a economic priority. But in the mitigation phase, it's always economic priority, because you can't go on with the containment period for a long time, that you have to move into the, to open up the country and make the life normal. So now the objective is to control the epidemic while the country is open. And the government strategy in Sri Lanka was a whole of government approach with military and police and all other sectors assisting health. But I think in the mitigation phase, that we have to move on to a whole of health approach. And again, there are 2 question marks in this. One thing is, during the containment phase, have we prepared enough for the mitigation phase? The other one is, can the health alone handle the mitigation phase? So why military? It's a frequently asked question in containment phase. So there are 2 reasons for that. For me, that is, a pandemic has a national security perspective. And in a pandemic, all the dimensions of the national security, like political, food security, economic security, cyber security, and also environment security is tied up with the health security. So it's going to be a huge national security threat to a country if we can't control the pandemic. So the military invariably are the safeguarders of national security. So that is one reason that Sri Lanka has decided to get the military involved in heavily. I think it's one of the few countries that this much of heavy involvement of military in the world in this pandemic response. The other reason is that in Sri Lanka, almost all the time, the disaster response is done by the military, because there is no civilian sector for the disaster response in Sri Lanka, even in health sector response, be it a natural disaster, man-made disaster. So the military comes to the forefront in at least for a few hours, 72 hours or so. But in this situation, it's a prolonged disaster response from the military. And we have all the capabilities, the qualities to engage in disaster response in the military. So what we have done during the containment phase, this is a not complete list, but the bulk of the work that we did was the quarantine process and contact tracing, I would say. And point of entry operation still exclusively run by the military, Air Force, Navy, and the Army with the help of immigration and other sectors. And so there are some areas that we have come into play, like patient management. We have a dedicated treatment center for the military at Panagoda Army Base Hospital. And also we discuss about the Kandekadu makeshift hospital that we converted the quarantine center into an intermediate care center. And also we had to start some damage control services that we never did before Minuwangoda cluster. One thing is patient transport. So we had to start patient transport services by the military with the eruption of Minuwangoda cluster. We also have testing capacity exclusive for military at Army Hospital, Colombo. So coming on to quarantine, that is one of the major things that we did by the military in the pandemic response. The Sri Lankan pillars are containment, detection, and treatment. In quarantine, the quarantine process was fed by the overseas returnees and also the local personnel who was identified at contact tracing. These are the numbers. So far, we have handled more than 80,000 persons during this 9 months period, and it's still going on. And we have got persons from the repatriates from 132 countries out of 207 countries and territories in the world, and we have been running 95 centers altogether during this period. So the outcome, so the objective was to contain the disease to quarantine centers in the containment phase. So we have more or less achieved that 83% of the cases have come from quarantine centers, if you exclude Kandekadu and Navy cluster. And those two clusters, again, they were in a camp setting, that they were not in the community. Most of their cases were not in the community. So we have achieved our purpose of having institutional quarantine in Sri Lanka. Coming on to the process, as we discussed, our primary objective is to contain the disease into the quarantine centers, but we didn't have the optimal condition with the suboptimal conditions. We had two other operational objectives: to minimize the internal transmission and also the safeguard the health workforce of the military. Not only the health workforce, all the staff of the military. And we followed very simple guidelines. We engaged least numbers with appropriate protection and with least exposure. Those were the simple guidelines we followed in this process, and nothing less, nothing more. We have been following this for now. So we adopted all general CBR and zoning principles with minimal staff. And the quarantine centers, actually, that's what the challenge. We had varying type of quarantine centers with dormitories in the most of the places. And it was a challenge to reduce the internal transmission. And we followed all the guidelines by WHO and other institutions, how to do a quarantine. and we did some certain triaging to minimize the internal transmission. And the testing we did we are doing entry PCR and exit PCR for the quarantine. We are still practicing that. Have we achieved our objectives? Now we have this first objective, the primary objective, as to prevent the transmission to the disease to the country. So there are only 4 reported cases from quarantine centers or persons who have gone out of quarantine centers. We had this one case from Akuressa 7 days after he left the quarantine center. He was a returnee from South Africa. And luckily, we have mapped everything, every single person in our quarantine center. We are still doing that. So we could trace down everybody who are in the community with their passport numbers, as you can see in the diagram. And we found one more case. We tested all 22 people in this dormitory. And we found one more case from Bandaragama. And there was a case from Jintupitia. He was a she marshal from a ship, and one pregnant lady from Bangladesh. Those are the only 4 cases reported who went out from the quarantine centers. But from these 4 cases, no clusters popped up. So the big question was when we started this, the internal transmission, whether everybody in the quarantine center will get the disease. So, as you can see, every country is doing what they are doing, the same thing. And the USA, Indonesia, many other countries. The worst one is the India and the bottom of the slide. And as you can see, these are some of the groups that we got from the repatriation flights. And the yellow ones are the definite internal transmission. As you can say, it's minimal. Very few people have got the disease from the quarantine centers. As we had the suboptimal conditions, it was a challenge actually. And also with the local clusters, again, the same thing, that we had not many internal transmission, but except for one instance where the Jaffna in Mailadi, we had a quarantine center. Except for one, all others got the disease, but it was not under army quarantine process. So then the next operation level, safeguarding the health frontline workers. We had few cases, but they were minimal, and we could handle it in such a way that we didn't have any spillage into our military camps. So this is just to figure out how large the process is. We have to, all these institutions come into play in daily basis, sometimes more than once in daily. So it's a very huge network and huge complex process. I will not have time to go to Kantekadu incident, I think. So to end my presentation, I would like to mention few strengths that we have had during the containment phase. We have a very strong public health system. That's why we were successful. And then about this hybrid contract tracing, that of course one of the unique systems that been implemented in the world, that we have the public health surveillance by epidemiology unit plus the military intelligence. They have their own surveillance. Then they get together and make the decision. The military intelligence done by the state intelligence services and army intelligence services. And we all know about the commitment of leadership in the country. It has been one of the strong points throughout this 9 months. And we had a good communication between health and military, again a strong point. So with all due respect to the physicians in the country, that we have been able to minimize the deaths in the country with proper patient management guidelines and their dedication. And to look at where we went wrong in the containment phase and why we are in this dilemma to now. So in this critical phase where we have a thrust now. So we had some loose falls, I would say, in our system with their crew quarantine, sea marshal quarantine, and with the airport staff, they were going home daily. and they were a vulnerability. And we had this frontline worker, a large force of frontline workers working in this huge exercise, health, the military and police and many other sectors. And then we had issues with testing capacity, as we all know, and the treatment capacity. And moreover, all the other things, that there was a very poor adherence to the new normal in the country. There were a lot of amplifying events in the country happening during this, the containment, the last few months of the containment phase. And we had loopholes in community surveillance. We couldn't catch the 3 clusters that happened in the country early. So we have now, still we are experiencing this dilemma or this situation, because we couldn't catch the epidemic early through our community surveillance system. And also we all know about the stigma and fear that was created by the media. And also, so it has the effect on the control of the pandemic now. So there was some good changes or positive changes occurred during the transition period from the containment phase to the mitigation phase. That was the decision. One decision that was taken was to home quarantine the contacts. Then there was a review of discharge criteria. So it has helped to to reduce the burden of active caseload in the country. Otherwise, if we hadn't this review of the criteria, it would have been a disaster by now. And then management of asymptomatic cases in intermediate care centers, and introducing the new testing strategy with the rapid antigen test. And also now there is operational center coming, which has come up in Ministry of Health. I think it will help to to go to the all of health approach in future without military getting involved much in the mitigation phase. So there are a few more things that I want to highlight that as way forward in the next phase of in the near future. So we can think of home-based asymptomatic patient management, home quarantine of repatriates, and then it's important to release the divisional hospitals to the normal medical service. We know what has happened to the normal medical services in the country, because most of the divisional hospitals are occupied by the COVID treatment centers. So if we can have the intermediate care centers plus few specialized centers, that would be the ideal model for the way forward. And we should have a formidable new normal when we come out of this thrust, and then strong ILI-SRE surveillance. And I think the way forward is whole of health approach in future. So that is all from me. Thank you very much. This was one of the rewards I got from one of the kids who was quarantined at Kandekadu. Thank you very much.
Thank you very much for a very interesting and very informative lecture, Dr. Savin Semage. Now I call upon Dr. Ananda Wijayakrama, President, Ceylon College of Physicians, to hand over the token of appreciation. Up next is the next topic is critically ill COVID-19 patient. The lecture is going to be delivered by Dr. Razin Mahrukh, his consultant in critical care medicine and anesthesia, Addenbrooke, Cambridge University Hospital. Over to you, Dr. Razin Mahrukh.
I wonder if you can hear me. Can you hear me?
Yes. Yes.
Great. I'll just share my PowerPoint very quickly, and we'll get started. Good afternoon, everyone. My name is Dr. Razin Mahrukh. I'm one of the consultants in critical care medicine, as you've kindly introduced me, and thank you very much for the opportunity to present today. Good afternoon to you all in Colombo. I would like to talk to you about ventilation in COVID, especially in severe COVID, and secondary infections, especially in these patients in critical care capacity. So without much ado, let's crack on. So just to highlight a couple of things that have come to pass over the last a few days to 2 weeks. It seems as if the academic community has been taking note of this conference. A lot of announcements that came out today and yesterday of interest. We do know that severe COVID seems to be associated with profound immune response, especially with regards to a blood profile, which is akin to what we might see in a hemophagocytic lymphohistiocytosis, and obviously a very procoagulant state in this. And I wouldn't touch on that. I know our following speaker, Anup Chauhan, who I used to work for as an SHO, so I wouldn't keep him waiting. So I'm sure he will talk about that in much more detail. But what I do want to highlight is about how there's emerging evidence coming through that immunomodulation seems to be a pivotal key role in trying to mitigate organ failure. And in doing so, we've seen the evidence for dexamethasone come through from the recovery trial. Interestingly, yesterday, the REMAP-CAP arm of recovery, which is the ICU critically ill arm, which showed that the use of tocilizumab, which is an IL-6 inhibitor, seems to be of significant benefit in these patients, especially with an odds ratio of about 1.89, which is higher than what was seen for dexamethasone in their detail. The paper is yet to be published or peer reviewed, but that's a statement from the group. We've today seen remdesivir being rejected by the WHO. Its evidence for that was very weak anyway, and it's not really useful in severe COVID, and we don't really use it in a critical care facility. We've seen lots of interesting announcements from different companies about the vaccine and the prospect for that, especially an mRNA vaccine that's been talked about by Pfizer and Moderna and so on. But they haven't published their data. But the first published peer-reviewed evidence was published yesterday from Oxford by Maheshi Ramasamy and the Oxford Vaccine Group colleagues of Sarah Gilbert and Andrew Pollard for the live vector version of the trial platform, which seems to show positive musings about a phase 2, phase 3 work, especially also in the elderly group, those who were questionable efficacy in the previous trials as to whether they would mount an initial antibody response. That's not to say that it will have a sustained antibody response or immune memory. There seems to be an initial reaction that is well tolerated, which is showing some hope. Having said that, just to put a context of where we are in the UK at the moment, the graph on the left here shows the previous wave up from spring up until the end of August, shows that the Southeast took quite a brunt from the initial wave, with London and us as well from a per capita side of things in the East of England taking quite a bit of a critical care hit from the wave that happened. In this wave, the Midlands and the Northwest is being pummeled as we speak. In the last 2 weeks, things are progressively getting worse, and I know that they are struggling pretty badly. But I'd like to highlight this graph on the right. If you look around, this graph shows ICU admissions across different regions in the UK. And the blue graph, the line, shows the cases that are coming through against time in the first wave in the spring. And it's following a very similar pattern throughout every region in that wave. However, the gradient of admissions this time around to ICUs across the region is different to the first wave, but within regions within this wave is similar. It hasn't got the same uptake. It hasn't got the same steep gradient that it had. And there seems to be a slower trickle through that's coming through to critical care admissions of severe COVID. And it'll be interesting to find out why. Is it because we're dealing with a different strain of COVID than we did back in the spring? We don't know. Is it because we're using dexamethasone in these patients who get admitted to hospital early, and therefore they're self-selecting out from being admitted to ICU, which we know has a benefit in these patients who need oxygen and hence have severe COVID? We'll probably find out with time. The point here is that each wave might have different characteristics for the critical care community and also hospital admissions as they come through. And between different countries, there may be differences in the way that this strain or this organism behaves in the way that it causes a surge, and that only that local evidence will be able to delineate much better than otherwise. This is some data from the critical care community that gets published from the ICNARC data of England, Wales, and Northern Ireland. And this from the previous wave, and this time round, it shows essentially about 90% of all ICU admissions were for people who were previously fit and well. We were not admitting necessarily people who are otherwise decrepit, but to show that even normal people get really bad disease from this, and they die from it as well. And it seems should be a public health message that we should be sending out. But also as a risk factor, we know that there are multiple risk factors, but there is a big risk factor in the fact that if you're overweight or obese, frankly obese, then your risk of having severe COVID and ending up on ICU is very high. About 3 out of 4 patients that we dealt with in critical care in the UK were overweight or obese. There is a debate as to which form of ventilation is useful for those with respiratory failure. We know that more than 15% of hospital admissions with COVID in the UK ended up requiring some form of high dependency or critical care support. But the problem is it more useful to give them non-invasive ventilation or CPAP, because there are some argument to say that CPAP reduces mortality, and we'll come to that discussion in a moment, or should we go on to mechanical ventilation, both with regards to management of these patients' respiratory failure, but also to reduce cross-infection between patients and staff and so on. We have heard a lot about phenotypic variations of lung compliance and recruitability, and the debate is probably crystallizing the fact that this is probably an evolution of the disease, and early on in the respiratory failure part of it, the pneumonitis seems to be a much more compliant aspect of the disease itself, and hence they are much more recruitable. And as it progresses and you have secondary infections and so on, the lungs become stiffer, less compliant, and less recruitable. And this was clearly delineated in the Gattinoni paper, or a statement that came out about the different phenotypic variations of the L and H type lungs. And if you look on the left side, you can see preservation of lung architecture pretty much on this CT, and volumes as well, with the pneumonitic pattern airspace shadowing, but there's not much with regards to collapse or consolidation, as opposed to a patient who on the right, for example, who has progressed to have much worsening consolidation and collapse, and a much stiffer set of lungs. And how you ventilate these patients is different. And hence, the response to using a non-invasive form of support, whether it's CPAP or ventilation, or invasively or BiPAP, they will respond to it in different ways at different times during the course of their illness. So is it correct that we then say that in this whole process of the L-type lungs which have low elastance and the progressing now to H-type, that if they manage, if giving them CPAP is the better form to improve survival? This is some data that's come out recently in October. This is from Wigan. Essentially claims that CPAP has an associated reduced mortality with it. But they also, you read through the paper, it becomes clear, right? If you have institute CPAP early in their disease and their period of requiring CPAP is short, they do better. But if it's long or prolonged, they do much worse. And hence, prolonging those who need mechanical ventilation and not giving it to them is counterproductive. There's also that that people who have a lower A gradient, otherwise alveolar arterial gradient, where the oxygenation is preserved, they do better with CPAP because they are less sick. If you're less sick, your risk of death is less. And therefore, if you're less sick, the need for mechanical ventilation is also less. So if it's severe illness, you need mechanical ventilation to preserve life. That per se doesn't mean that mechanical ventilation increases your mortality. It's just a surrogate for worse, severe form of the illness. So to say that CPAP per se reduces mortality is slightly misleading without taking the rest of the facts. But we could adjust the CPAP and to give them CPAP or some form of non-invasive ventilation whilst in a prone position. And this is a paper from Oxford that has looked at that. And there's still some work that's going on in the recovery arm of respiratory support as looking into these aspects, not with mechanical ventilation, but with regards to standard care and different forms of non-invasive support. And they will hopefully report soon, and we'll find out some bit more detail about it. Without much ado, mechanical ventilation itself in these patients can be rather tricky. They are very sick, they're usually requiring high amounts of oxygen, and they, getting them off to sleep can be hazardous. But soon after they go to sleep, especially if they have L-type lungs, they do recruit very quickly. They make a fool out of you because they look very good at the end of the bed. They come from requiring 80% to 30% in a peak of 5, and you wonder why you intubated them. But you give them time, and they progress from the L to the H-type lungs over a period of time. So don't be tempted to extubate them too early and let this course play itself out. And the sedation synchrony of the ventilation becomes a paramount part of managing these guys, especially who have L-type lungs and progress on to H-type. Relaxation is a fundamental aspect of advanced mechanical ventilation, and we've used inhaled prostaglandin I2, hyperprostenol, prostacyclin to try to improve the VQ matching in these guys to not much effect. In fact, we found prone position ventilation is much more responsive and effective in these patients than inhaled prostaglandins. They also become tachyphylactic to it. I'll show you a little graph in a moment. But strict fluid balance as it comes coming out of the ARDS network, and you even using hemodiafiltration and ensuring anticoagulation, and that's something that Anup Chauhan is going to probably talk about, is going to be very useful in these people to keep the lungs reasonably dry. So therefore improve the oxygenation and ventilatory capacity in increasingly dense H-type lungs that are becoming, coming to be in these patients who stay on ICU for a prolonged period of time. Of course, veno-veno ECMO is another possibility in these patients. I'm not sure how much capacity or access you have for that. And we found the response to veno-venous ECMO is about half and half in the critical ill severe COVID patients in the UK at the moment. A report is due to be out soon. So this is a graph of someone we proned. The arrows indicate the orange line where their inspired fractional oxygenation requirements were about 100%. And every time they got to about 100%, we turned them prone, and the oxygen requirements came down quite nicely, as you can see. So they get prone, they come down, and then go up again, then prone again, they come down, they go up again. So there's a good response, but progressive proning efforts seem to have a reduced response to it and reduced yield to what's going on. So we found a very useful thing, but a lot of these patients are 150 kilos. Proning someone who's 150 kilos and 100% oxygen, still connected to the dialysis machine with 3 inotropes and vasopressors, is not an easy thing to do. And it requires, a team that is well-trained and has been doing this and is aware of all the dangers and problems. So that having that up front as part of your ICU team training is a useful thing going into any surge with these people. This is the sort of lungs that we dealt with and the ones that we prone, but I won't delve into this too long because we just want to transition to the second part of this talk in the interest of time. But they are, can be very difficult to try to maintain oxygenation and ventilation in a set of lungs that look like this. So overall, we are dealing with a disease that is slow to progress. Therefore, we need to give it time. We need to have resource and capacity to give it time. In our experience, our mean duration of stay in the ICU was 12 days for these patients. And we had chaps who were here on the unit ventilated on a tracheostomy weaning multiple times for 68 days. That was our longest stayer who survived, in fact, to go home. So, but we ventilated about 87% of these admissions, and we've now had 126 patients through ICU, about 800 through the hospital. About a third of these patients require dialysis, and they need dialysis. They need it for about 12 days. There were times that we had to have a dialysis rota because we were running out of resource and staff, and we ultimately started getting even sled machines to try to help our dialysis effort for these patients to maintain their renal support. So it's a huge burden on resource, and it's a huge burden on time as well. But going on to the aspect of secondary infections become increasingly important, it appears, as we try to understand their ICU stays. With the prolonged ICU stay, with the immunomodulation especially becoming the way forward with these ones, dexamethasone, tocilizumab, we're going to see increasingly the possibility of ventilator-associated pneumonia and other secondary infections related to catheters of all sorts, lines, urinary catheters, and so on. We are also compounded by the fact that it's hard to diagnose, and it increases ICU organ stay, organ support, and mortality. But the next important thing here is that why is ICU-acquired infections so common? And the biggest risk factor here, what it looks like, is a requirement for organ support, but also that they remain to be in a balance between immunosuppressed, but also some degree of increased immune response in the initial stages that cause some degree of organ injury. The protective mechanisms that you normally have in the body, your ciliary clearance, for example, the skin that is not broken, that requires lines and etc., are now being invaded. So therefore, normal biological protective mechanisms are removed. And those who require prolonged stays and multiple courses of antibiotics, whether you have a carbapenem, piperacillin tazobactam, meropenem, added vancomycin, amikacin, or any other carbapenemase flavored drugs that you want to use, there's a reflection of the ongoing immune failure that they see in patients who persist in this sort of state. So therefore, the immune exhaustion that you see coming through it puts them at risk of developing further complications from prolonged stay in ICU, which patients with COVID seem to increasingly have. I'd like to highlight this paper from China early on in March. Zhu and colleagues produced this data that showed a very interesting outcome here, for example, that essentially to say that patients were admitted to ICU around day 9 or 10 of their illness, and 7 days later, there was a spike in secondary infections also, as you can see, in day 17. And notably, in keeping with the reports from elsewhere, a few of these patients presented with primary co-infection, which is where this disease really differs from influenza. So when they come in, they seem to have just COVID. Hardly anybody had a secondary community-acquired pneumonia or the bacterial pneumonia we seem to see with influenza A that come through at the door. They seem to have COVID. And we found ourselves increasingly stopping their antibiotics at the start of the course of their ICU, waiting for the secondary bacterial hit to come through so that we can preserve our antibiotics in these patients. So when this data was first revealed, there was some skepticism. There seemed to have arisen in part of the empiric use of immunosuppressive therapies and steroids, but we didn't necessarily use it. We were only using, this was before the dexamethasone data that came through, and we weren't using the drugs as such other than in trials at the time. So this is pure evidence that's coming through. The secondary infection, right, is common in these people when they present. They just have an isolated COVID viral illness. This is data from Garcia and Vidal. So we've had a lot of data come through about COVID, and sometimes it does rush through unnecessarily. It's done some harm, I feel, not having properly peer-reviewed, and it's difficult to retract, erroneous data that's been published out there. But relative to the large amount of COVID literature that's out, there's relatively little on nosocomial infections. And broadly speaking, reports that do provide detail fall into two categories. Right? Those that look at the totality of the COVID hospitalization and those that focus on the most severe forms of severe cases in ICU. There is almost no published literature is in the direct comparisons with non-COVID patients exposed to the same environment. This paper, is from Garcia Vidal, has come through, and colleagues at Barcelona. They reported hospital-acquired infections, a large cohort of about nearly 1,000 patients. The overall rate was low. Around 5% of the patients developed hospital-acquired infections, although nearly 70% of these patients were admitted to ICU. It's unclear how many of the infections were acquired before ICU care was required. So there seems to be a preponderance to acquiring these. And the organisms reported were similar to the usually suspected causes of hospital-acquired infections like Staph aureus, E. coli, and Pseudomonas. they did report 3 cases of Aspergillus that we'll talk about briefly if we have time in a moment. I'll quickly touch on this. For example, there's a multi-center study from the UK from Vanya Gant's team at UCH who are running the INHALE study, which randomized a trial of multiplex multipathogen array, showing 94 patients who were investigated for ventilator-associated pneumonia in 5 different ICUs. And all patients investigated were suspected VAP or hospital-acquired pneumonia, and 54%, more than half, were positive. And the dominant organisms in this group were Klebsiella and Staph aureus, as we've seen from their isolates. How about fungal infections? This is a letter that came through from the American Journal of Respiratory and Critical Care Medicine back in July, showed that, aspergillosis seems to be much more common than we think in this group. And there's something that we need to start paying attention to. And in a cohort, we found that there was a report of more than 50% of their, bronchoalveolar lavages isolated fungal infection or fungal presence as a possible cause for their ventilator-associated pneumonia. So what was our local experience in the last couple of minutes? We had quite a busy period during our COVID surge, and by any standards, it was difficult. We've had in total 116 patients come through now, and we ventilated over 100 of these, and all of them for more than 48 hours. So that everyone, in theory, has a risk of ventilator-associated pneumonia. And more than half of them developed an acute kidney injury, and a third of these people required renal replacement therapy. Median stay, they said, was now increasing to 14 days, and ventilation was 14 days as well. So in essence, one would expect for them to have high degree of secondary infections. The question is, did they have it? So 49% of our patients, by the defined normal criteria, had a ventilator-associated pneumonia. And just over half were diagnosed by quantitative culture of their bronchoalveolar lavage. And what's interesting is that the incident density of their ventilator days was very high. And you can see from the graph on this side here, COVID versus non-COVID survival without VAP for ventilator patients were very starkly different, right? Probability of VAP-free survival for non-COVID patients seemed to level out after about 3 weeks or so. But there's increasing probability that the patients with COVID will be increasingly at risk of developing a VAP, and therefore an increased risk of death and increased ICU stay. The bugs that we isolated were no different to what we would see in COVID and non-COVID patients. While it's a colorful picture, essentially there's no difference really in the bugs that we see. So we don't necessarily, just because they have COVID, they don't get unusual organisms other than Aspergillus that seems to be occurring much more commonly in this group than otherwise expected in VAP. Sorry about this busy diagram. In the interest of time, we sequenced 24 patients for the presence of different bugs in their bronchoalveolar lavage, and those who were COVID negative on the left, shown here from patient 15 to 24 here, patient 1 to 14 who had deep lung samples who are still viral antigen positive, and their bugs that we isolated as a presence of the bacterium, and those who are recovering and the viral antigen negative from their deep lungs did not show any particular pattern in the way that they acquired these bacterial organisms at all. So they get infected with VAP, the normal bugs that you have, but they get infected more frequently. This is something that has helped us quite a lot. Precision diagnostics by essentially a system that we have using a bronchoalveolar fluid and using a system called a microarray technique that looks at essentially 52 different organisms of 96 different sequences. It can be done very quickly, developed by what we call our microarray ninja, Dr. Martin Curran there. Is a very useful thing to try to precisely diagnose that we use very frequently in Cambridge and Addenbrooke's, and that helps us both with regards to targeting our antibiotics for ventilator-associated pneumonia, but also in stopping antibiotics in patients who we think might not necessarily need it, both from a clinical as well as from a diagnostic criteria, and that's helped us immensely. To round off very quickly, See, it's not just about VAP. There are other bloodstream infections that are happening too. It's much more common in these patients, the candidemia as well as a coagulase negative staph. And we are looking currently at the moment of comparing our data with non-COVID patients in the past. And we will see the outcome of those very soon. Something to mention, we are very strict, with regards to line insertion and handling with regards to asepsis. It's a full aseptic technique when any lines go in on the unit. So, and it's not changed before and during COVID. So they're seeing a real change in secondary infections in these patients who are stuck on the unit for a prolonged period of time or immunoparesed. One quick mention about the C5a side of things. There seems to be some degree of, this is Manu Shankar-Hari's work about the HLA-DR expression, and there seems to be reduction in that aspect. In patients with COVID, there seems to be initially an hyperimmune response that causes some degree of the damage. It puts them on a critical care bed, although they seem to then become depressed and suppressed after that. And those we know that have increased amount of HLA-DR expression, especially in the latter stages, are prone and susceptible to developing a secondary infection. We're seeing that increasingly in COVID patients. So therefore, it might not be that the COVID that kills them and they come through to critical care. It may be that the secondary infection that either gets missed or not treated or not appropriately antibiotic covered for their illness or lines changed and so on. So I wouldn't go into that too much. Essentially, to say that that we have developed ways of trying to reduce the cross transmission of because of the fact that we need to get into these lungs. It's an aerosol generating procedure. There is a risk of developing and the users and staff catching COVID off the patient, especially in the patients who have, a raging COVID, as it were, we call it, hooching with it in their lungs. And we've published ways that we've developed to try to reduce this cross-infection. And in this paper, for anyone who's interested and wants to stay safe, but still be able to assay these deep lung samples so that bronchial lavages can be done in time. And we have not had a single staff member infected doing this procedure during the last 8 months of doing it, which is really reassuring. So in summary, ventilator-associated pneumonias and other secondary infections are very common in COVID-19 patients, and most of these patients are treated for equivalent lengths of time in the unit. So there's much higher risk of these, and the organisms and resistance patterns do not differ from the normal unit flora. So therefore, local antibiotic regimens and criteria are absolutely appropriate and will be guided by local transmission and flora. Invasive aspergillosis seems to be a pattern that's coming through in these patients that seem to be more susceptible. Obviously, associated risk for these patients is much higher, especially with regards to their mortality. And we can use lower respiratory tract samples, and it's vital, and it can be done safely, and especially with the technology that is being developed. And what we're using here, the microarray technique, for example, gives us much more use of and precision of using this in a targeted manner in different patients. And I'm hoping that it will develop in time to come. With that, I'm sorry to have taken a bit longer than I intended. I'm very happy to take any questions or comments, and thank you very much.
Thank you, Dr. Maharoof, for that excellent overview. Especially thank you knowing how busy you are these days. And it's really valuable to share your experience. We really appreciate your participation in this. Thank you very much. Just a couple of questions until we see anything. What time do you start them on anticoagulation, these patients?
So we have obviously a normal protocol of low molecular weight heparin that we use as a prophylaxis for patients who don't need formal anticoagulation. Our hematologists produced some data about the procoagulant effect of COVID, and we were seeing increased amount of clots happening. So arbitrarily, for anyone who is COVID positive who needs prophylactic low molecular weight heparin, we double their prophylactic dose. So if we use dalteparin, normally for someone who's less than 100 kilos, it'll be 5,000 units a day. We use 10,000 units per day, for example. But we found that these same patients who need prophylactic dalteparin, who say, for example, need hemodiafiltration, they clot these filters off very quickly, despite being on a standard unfractionated heparin anticoagulation for these hemodiafilters. So for those patients, we have formally anticoagulated them either with unfractionated heparin or treatment dose low molecular weight heparin. Our clot burden seems to be pretty high. We've published a separate set of data about how frequent a venous thromboembolic episode seems to occur in these patients despite anticoagulation.
Thank you very much. Since we are running out of time, we'll stop the discussion here. Surely we will arrange another meeting with you to discuss our burning issues. Once again, thank you very much, Dr. Maharu, for joining with us.
Thanks very much for having me. Good luck.
Right. Up next is the lecture on COVID-19 update on pulmonary microangiopathy. The lecture is delivered by Prof. Anup J. Chauhan. He's Associate International Director to South Asia in Royal College of Physicians, London. Over to you, Dr. Chauhan.
Good day. Thank you for the invitation to be able to give you an update on pulmonary microangiopathy and COVID-19. I apologize, I'm unable to be there in person, but hopefully this virtual lecture will be sufficient. We recognize that the global impact of coronavirus infection traverses the whole of society, medicine, and as the time of recording of this video, there are over 1 million deaths as a result of COVID infection across the world. And as you can see, that's broken down across the continents, and it's huge, and it's no different across many parts of South Asia. We also recognize that many patients do recover. So what are the differences between those individuals who can, who can't recover, and also how does that belie the underlying mechanisms? Well, firstly, we recognize that the primary symptoms of COVID are fairly common, as we may well know from our practice. It starts with a headache, cough, sore throat, congestion, loss of smell, then shortness of breath, and then more systemic symptoms of malaise, vomiting, and diarrhea. And these symptoms can occur anything from 2 days up to 14 days after exposure to the virus. We can now grade patients based on the severity of the illness, and these are the NIH guidelines categorized by mild, moderate, severe, largely dependent on their symptoms, but also their oxygen requirements. Patients with moderate illness have saturations of 94% or above, but have lower respiratory disease as evidenced by clinical assessment. But those patients with severe illness are those with saturations less than 94%, with a PaO2, FiO2 less than 300, a high respiratory rate, and or lung infiltrates on the imaging. Those individuals with critical illness are those with much more fulminant respiratory failure, septic shock, and multi-organ dysfunction. The variation in the clinical course and outcome among patients hospitalized with COVID has been charted, and this is from a study in Wuhan published earlier this year. And it shows the differences between 137 survivors and 54 non-survivors. And you can see comparison of the charts here is that there was not much difference in terms of the duration of fever, the cough, the breathlessness, and also the ICU admission. And also the number of patients who did receive systemic corticosteroid. However, the differences are largely around the development of ARDS, but other extrapulmonary manifestations of COVID infection, such as cardiac injury and renal injury and sepsis. And you may not be able to see that because of the video. But again, the multi-organ survive. So when we think about the extrapulmonary manifestations, there are many. There are skin changes with petechiae, urticaria, pernio-like lesions. And there are neurological disturbances with encephalopathy, Guillain-Barré, stroke, and then thromboembolic disease, abnormalities in liver function, microvascular injuries in the kidney, and then gastrointestinal disturbances with diarrhea, abdominal pain, vomiting, and then disturbance of pre-existing diabetic ketoacidosis, and then significant cardiac effects from cardiomyopathy, shock, ischemia, and arrhythmias. So when looking at a patient with developing respiratory infection from COVID, a common hallmark are the features on the chest CT, and they include bilateral peripheral ground glass opacities and consolidation of the lungs with the peak lung involvement. And this occurs at about day 6 or days 11 after infection. And in this study from Wuhan in China, this was a serial chest CT imaging demonstrating a sensitivity of 97% and a specificity of 25% with patients with RT-PCR as the reference for the presence or absence of infection. And what you can see is that there are mild infiltrates that are barely visible at early in the infection. But as the disease progresses, you can see much more ground glass opacities, especially in the peripheries, even up to day 23 in this individual who survived. These changes are noticeable, but note that these changes are not that remarkable. Compare that to those patients who require ICU admission. They get much more florid changes in their lungs with ground glass opacities. So there are differences, but the CT scans can detect very early changes in the lungs. When we look at the comparison between the radiographic and lab abnormalities by the disease severity among COVID patients, this is a study from COVID-19, it shows some really interesting results. What you can see is that abnormalities on the chest radiograph and chest CT are fairly common between those who are classified as non-severe and severe disease. But the differences really come on the systemic manifestations. There's a much greater reduction in lymphocyte count, a reduction in platelets, much higher levels of mean, or the number of patients with raised CRP is much greater. LDH is increased, but also abnormalities in liver function are more common in those individuals with more severe disease. And when we look at the imaging, a significant pattern emerges. And this is a CT scan from an individual with DECT scanning, looking for areas of hyperperfusion. So in the areas of infiltrates, you can see quite obvious peripheral consolidation. But using DECT scanning, one of the things that you can also demonstrate in those areas and other areas is this hypoperfusion and slightly dilated pulmonary arteries, suggesting that there is an angiopathic component in these patients developing the COVID-like pneumonia. So is SARS-CoV-2 pneumonia similar to previous SARS infections and MERS? Well, is the severe lung disease really like ARDS? And some of this came from earlier description from post-mortem studies that showed quite significant diffuse alveolar damage in early histopathology of some of the SARS-like pneumonias with lots of inflammatory cells, hyaline membrane, desquamation, and then also edema. But two unusual findings are different in patients with COVID pneumonia. It's becoming clear that the SARS-CoV-2 pneumonia lungs do indeed have that diffuse alveolar damage, but they also have evidence of disruption of the microvasculature through thrombosis. And in particular, in this immunohistochemical staining, there's increased levels of C5b, which is the terminal effector of the complement cascade. Further post-mortem studies from northern Italy and Germany showed that diffuse alveolar damage is noted in multiple small post-mortem studies, as you can see here. But also, more importantly, is this platelet-rich fibrin-related coagulopathy observed in the smaller arteries, arterial vessels of some of these patients as well. So the angiopathic features occurring hand in hand with the diffuse alveolar damage. Further studies show that in autopsy finding from 12 patients, 7 out of 12 patients had unsuspected bilateral DVT. And in those individuals, there was indeed alveolar damage, and 4 of those 7 had died from a pulmonary embolism. And their lung again shows this organizing microthrombus. So when we look back at the burden of thrombosis in patients with COVID-19, we find some surprising features in these studies from China, France, Netherlands, Italy, United Kingdom. It showed that in patients who are hospitalized or at least requiring intensive care treatment, whether they receive thromboprophylaxis or not, but what you can see is that the VTE rate, the venous thromboembolic rate, is quite significant. Almost a fifth to a quarter of patients will have venous thromboemboli if they require ICU care for their admission. So there are other abnormalities that occur in those individuals with these thrombotic manifestations or those patients without. And from a biochemical point of view, what we find is that the D-dimer levels are much higher in those with thrombotic complications, as are the fibrinogen levels, and the CRP, surprisingly, is also increased as well, suggesting a parallel increase in systemic inflammation as well as markers of coagulation. So the ESR is also raised, as is the ferritin. So there's a lot of systemic inflammation and thrombotic risk. So why aren't we always seeing the typical ARDS in SARS-CoV-2 pneumonia? Well, on the left-hand side, I've illustrated what happens within the alveolar architecture, where we have the presence of type 1 and 2 pneumocytes, the protective surfactant layer, the fibroblasts, and also the intimate relationship between the alveoli and the accompanying endothelial vessels. But in an ARDS picture, you get increased neutrophil activation, you see fibrin deposition within the alveoli, increased cellular debris, you get an expansion of the interstitium, and then you get an increased endothelial disease with the presence of more neutrophils in the airways, and also more platelet stickiness and inflamed endothelial cells. So an increased endothelial dysfunction with increased gap formation within the endothelial cells. However, thinking more about the microangiopathy, we can probably relate that disruption to Workhouse triad, which suggests that the three changes that occur in COVID pneumonia is this vascular endotheliitis or endothelial injury. There's a hypercoagulability as a result of platelet activation and other thrombotic factors. And then there is also that stasis as a result of reduced flow in those individuals. So one of the reasons that we are seeing microangiopathy may well be due to this Workhouse triad, in addition to the typical ARDS. So how could all this be linked together? Well, we recognize that endotheliitis is important, and it's postulated to be a central feature of the pathophysiology of COVID-19. We also recognize that ACE2 is a transmembrane receptor, which is widely expressed throughout the lungs, heart, kidney, and gastrointestinal tissue, and that SARS-CoV-2 binds to host cells within the ACE2 receptor as well. And not surprisingly, the highest density of ACE2 receptors will occur on endothelial cells. So therefore, the endotheliitis and viral inclusions have been demonstrated in elegant electron microscopy studies, and they show this close relationship between endothelial infection and also disruption. So these are the features of a study published by Ackerman. You can see the electron microscopy features between normal and COVID-like pneumonia. You can get much larger pores within the endothelial cells, but also further inclusion bodies suggest that there is a direct infection as well. But we also see some of the changes in the surrogate differences between patients with COVID-19 and, in this case, influenza A and controls. And you see more angiogenetic features in these individuals, and also the difference in types of angiogenesis. This is the density of sprouting angiogenesis, and also this is the intersusceptive type angiogenesis. So both pathological mechanisms of angiogenesis seem to be playing an important role. So when we think about those organs that express ACE2 cells, well, clearly in the lungs, but also in the myocardium as well as the vasculature. And this is where we get the association of vascular inflammation, endothelial dysfunction, and this is why the endothelial and microangiopathy may well determine the severity of the COVID-like pneumonia as well. So which patients are likely to have endothelial dysfunction? Well, this is a chart showing the predictors of mortality among COVID-19 patients as well. And as you can see, there are significant risk factors. So age, but also gender, male gender, presence of chronic cardiac disease, chronic pulmonary disease, chronic kidney disease, diabetes, obesity, and neurological disorder. So this prospective cohort study of all the hospital admissions in England and Wales, 20,000 of them, showed an significantly increased risk of mortality among older patients, men, and those with chronic comorbidities. And then further studies suggest that actually ethnicity is a huge factor as well. And the Open Safely Health Analytics platform, again, across 17 million adults, of which there were 10,000 COVID-related deaths, show a very similar story. Their male gender, older age, deprivation, but comorbidities provide an increased risk, as does the ethnicity as well. And this has been confirmed in the ICU-ACQUIRED studies of patients hospitalized in an ICU across England and Wales. Again, ethnic minorities were younger, they had diabetes and needed ventilation compared to their white counterparts. So their adjusted mortality was significantly higher. So what is the relationship between coagulopathy and thromboinflammation? Well, we see this across a variety of diseases, and I've summarized this in this slide here, whereas the balance between thrombosis and inflammation occurs in different diseases. So we recognize that actually inflammation is quite predominant in diabetes and hypertension. But as we see pathological changes occurring in other diseases, such as sepsis, you see that balance shifting between inflammation, increased expression of coagulation, both at a biomarker level, at a pathological level, but then again at a clinical level, where you then begin to see venous thromboembolic disease as well. And COVID-19 has an important role in terms of determining how a patient recovers based on the balance of inflammation and the thrombotic risk. So the systemic vascular endotheliitis and thrombosis is recognized, again, to confirm that this diffuse alveolar damage has been seen in those post-mortem studies. Again, also the ACE2 receptor, again, widely expressed in those areas as well. But more importantly is the co-localization between the anti-C5b reagent, which is the anti-C5b is a complement activation, but also being present in where the virus has been detected by staining by co-localization. So you can see the differences between the green and the yellow areas. So suggesting that the C5b9 activity in the alveoli and SARS-CoV-2 co-localization may well be linked. And we see that confirmed in several studies. The link between C5a, which is a downstream complement, and the relationship between the cytokine storm according to the severity of disease. In this study from Gao et al., patients with more severe disease had higher levels of serum C5a. And this other study here suggests that those patients with more severe disease, classified by requiring critical care, the expression of IL-6, RANTES, and a series of other cytokines was also higher as well. So this is in keeping with the picture where we see systemic inflammatory response with a high rise in CRP, but increased thrombotic risk. But is the thrombotic risk related to complement? So this is the summary of my hypothesis between the linkage between SARS-CoV-2, complement, and cytokine. And there are sort of six key features that I'd just like to outline here. Shortly following infection, the SARS-CoV-2 through the ACE2 receptor localization causes a vascular endothelial disruption. And then through complement, depending on the lectin alternative or classical, generates complement activation. And here seen by C3 and C5a. And they all have a significant role in immune modulation, lysis, and cell damage. But the expression of C5a and its presence again then triggers a downstream series of events that leads to chemotaxis, signaling and cell activation. So for example, C5a, through the effects on B cells, T cells, and neutrophils, may either cause an immune paresis, as illustrated by reduced interferon and IL-2, or an increase in the cytokine storm, as we've seen in some of those critically unwell patients as well. But similarly, C5a also drives tissue factor expression and from multiple cellular sources. And we know tissue factor will then act as a stimulus for procoagulation through various mechanisms, through prothrombin, thrombin, fibrin, fibrinogen, but eventually leading to the expression of D-dimers and FDPs, but also microvascular thrombosis. Similarly, C5a has effects on net release and the neutrophil cellular debris, but also important implications on plasminogen activating inhibitor, which reduces fibrinolysis. So it reduces the conversion of plasminogen to plasmin, so impairs fibrinolysis. So complement may well be critical here in these individuals, where it's related to microvascular thrombosis, coagulation, inflammation, and impaired fibrinolysis. And if we look at closely those diseases where you see a microangiopathic features, we also find actually complement plays a huge role in those individuals. So those with hemolytic uremic syndrome, C3 glomerulopathy, antiphospholipid syndrome, and post-stem cell transplantation, we see a very similar picture as well. And the thing that they have in common is that terminal complement pathway dysregulation, with increased C5b9 is similar to what is reported in SARS-CoV-2 pneumonia. We have some molecules, eculizumab and namaquipam, which are anti-C5 antibodies that could possibly have an important role in those individuals as well. So therefore, treatment with complement C5 inhibitors in transplant-associated TMA, especially in children, has been found to significantly reduce morbidity and mortality in this patient. So he has significant potential for use in COVID-19. Similarly, recognizing that treating the thrombotic risk, does it improve survival? Well, in this prophylactic anticoagulation therapy study from Wuhan, China, demonstrated this in those patients stratified at 28 days on whether they received prophylactic therapy in blue or no heparin. And as you can see, there was no survival advantage of those individuals with D-dimers that were not particularly elevated, but as you can see, the higher the D-dimer levels, the bigger the difference or the survival mortality as well, suggesting that physical anticoagulant prophylactic treatment may well reduce the mortality by helping that. So this is a summary of what happens in terms of severity of illness, the viral response phase that occurs following early infection, and then there's a host inflammatory response phase kicks in. And this is where they see the indices of hyperinflammation. And we know that some treatments have gained recognition and traction, including remdesivir, dexamethasone, and oxygen. And they may well be improving the host inflammatory or reducing the host inflammatory response, and as a downstream consequence, reducing the mortality and morbidity. So the benefit is clearly demonstrated in those individuals with at least COVID pneumonia and hyperinflammation, but the benefit in much more milder infection remains to be seen. So I've summarized this, the linkage between the SARS-CoV-2 complement and cytokines, and as illustrated by time series studies, again from China, and when and where we're likely to see the systemic inflammation and the thrombosis risk. So within the first couple of days, days 3 to 7, you get the infection, endothelial activation, reduced interferon gamma and IL-2, and then complement activation, thrombosis, innate immune response, the cytokine storm, and the angiopathy. And this activation of this innate immunity, complement, and maladaptive inflammation coagulation may well determine the disease course. And subsequently, patients then develop respiratory failure, more typical ARDS, and then the other organ damage that occurs that then determines their survival. So in summary, ACE2 receptors are present in multiple organ systems and the endothelium. COVID-19 causes significant endotheliitis and associated multi-organ pathology, and that comorbidities with pre-existing endothelial dysfunction may well pose an enhanced risk to that. COVID-19 TMA may well occur without the typical features of an ARDS. Complement overactivation could potentially drive many of these features as well. And anticoagulant prophylaxis is of benefit and has been supported by many subsequent guidelines. Other treatments that modify associated COVID-19 inflammatory syndromes, as we've seen with dexamethasone, will reduce and help. But more intriguingly, complement inhibition may also have a role in COVID-19 microangiopathy. Thank you.
Thank you, Anup. Thank you very much for that comprehensive overview. That really helps. Would you mind answering a couple of questions?
Yeah, no problem.
You said the anticoagulation prophylaxis may be of benefit. Have you considered giving aspirin to these patients, low-dose aspirin?
It's a really good question, and we don't have enough data to show that, but it would be sensible, and especially in those who already have pre-existing diseases. So aspirin should be continued. One would think that at least on a clinical pathological level, they will reduce platelet adhesiveness as well, and they may also improve some of the endothelial dysfunction, but it's not been tested. But in those individuals already on it, we'll probably continue it.
Once again, thank you, Professor Johan. Since we are running out of time, We will stop the session now, conclude the session now. And once again, thank you very much for joining us.
Right, no problem. Have a good session, everyone.